Hey, hi folks. I'm Bianca Frogner. I'm a professor at University of Washington in Seattle, and I direct the Center for Health Workforce Studies. I also am the chair of the webinar committee for the Award Network, and I sit on the leadership committee of the Award Network. Well, happy New Year's to everybody. Welcome to our third annual speed sharing event for where we are sharing our network members' research. We will get back to this shortly, but we have seven fantastic presentations. I do want to just let folks know, of course, that we have an upcoming webinar in February here, where we will be hearing about a partnership between nursing homes and nursing schools, a model that's being done out in Pennsylvania. You can find all of our webinars upcoming and register for them by scanning that QR code there. We always want to hear from you about ideas that you have for future webinars, which you can also provide us via that QR code. And then you can also find all of our prior webinars, including the one today, that are recorded online on our website. I do want to remind folks, if you haven't seen the announcement yet, we have another round of the Award Network Pilot Awards coming up. It's due on February 28th, and you can find details online on the website. These are meant to support early stage researchers on any ideas you have. We have two sets of awards that you can apply for. One is a full award up to $25,000, and there's also mini awards at up to $5,000. And so the details on the differences between those two awards and what we're looking to support can be found on the website. Again, I want to thank our wonderful webinar committee members who help organize all of these series of webinars. I really can't do this without them. And also want to recognize our leadership committee members, some of who are here today with us. And then, of course, we want to acknowledge our funding from the National Institute on Aging, who is supporting the award network, including this webinar series. So I want to make sure we leave plenty of time here for our speakers because there are seven of them and they only have about 7 to 8 minutes to present. We're going to go in reverse alphabetical order by last name. We don't really have any time to have Q&A much between presentations, but I do want to encourage people to use the chat function to interact with our speakers and ask them questions and have that being answered simultaneously. And I also want to encourage folks to reach out to our speakers afterwards if you have any questions, because the hope here is that we facilitate conversation. So we're going to kick off the presentations with Jiani Yu. She's an assistant professor in the Department of Health, in the Department of Population Health Sciences at Weill Cornell Medicine. So I'm going to have her go ahead and start her slides. Gianni, do you want to turn on your camera?
Sorry. Yeah. Okay. Let me just share. Okay, you're seeing the slides, right, in full screen?
Perfect. Yes, thank you. Go ahead and take it away.
Which, yeah, I've never been first before in any lineup, so this is exciting. Yeah, thank you for having me here. I'm excited to share some early stage work. I very much welcome any feedback or suggestions. This is, as I said, these are still early findings. So this study is called Examining Telehealth Use in Skilled Nursing Facilities. This work was supported by the NIA, and I'd also like to acknowledge my collaborators, Dr. Jung, Dr. Wen, Phyllis Johnson, and Ricarl Pierre. Okay, so as many of us here today, of course, know, skilled nursing facilities provide post-acute care, short-term skilled nursing, and rehab services, and account for over half of all Medicare spending on post-acute care. About a quarter of patients in skilled nursing facilities also have a diagnosis of Alzheimer's disease and related dementias, and this population has higher rates of hospitalizations and emergency department visits than the general population. And so, telehealth, which encompasses audio and audiovisual synchronous and asynchronous encounters between patients and providers, may provide these patients and SNFs with more timely, high quality post-acute care, particularly for those patients with ADRD. Now, passed at the very end of 2024, the American Relief Act of 2025 includes a short-term extension of Medicare telehealth waivers that do cover telehealth delivered SNF services, but only through March 2025. Without this extension, telehealth would have reverted back to its pre-pandemic levels of coverage and may still revert back to those levels of coverage. And that includes coverage only in rural areas and only in certain healthcare settings. And so there are potential advantages and disadvantages of this broader telehealth coverage and potentially, permanent expansion of telehealth for Medicare beneficiaries. And so these advantages and disadvantages do deserve some attention and further evidence. So among advantages, after-hours telehealth may provide patients with timely assessments, reduce the need for transports and hospitalizations. Regular access to telehealth may also provide SNF patients with the option to receive timely consultations for both acute issues and specialty care, which may reduce delays in diagnoses and the development of downstream conditions. Telehealth can also more easily bridge communication virtually across multiple parties that may facilitate more frequent touch points for patients. And that includes, bridging communication between patients, families, caregivers, and the care team. There are, of course, many disadvantages potentially for for telehealth use in this patient population, and those include telehealth requiring technological literacy, being able to use web-enabled tools to get online and to troubleshoot equipment when things go wrong during a visit. There may also be fewer visual cues to rely on during telehealth visits, and lower physician-patient engagement. Patients with ADRD may also have difficulty adapting to these newer methods of interaction that include, that potentially require more concentration and recognition. And then, of course, the longstanding staffing shortages in SNFs may be a barrier to facilitating telehealth use in these facilities. Ultimately, whether or not increased coverage of telehealth services improves quality of care for patients in SNFs does require research. And so in this study, we set out to examine the patterns of telehealth uptake in SNFs after the expansion of Medicare telehealth coverage. We also sought to estimate the relationship between SNF telehealth provision and utilization for all SNF patients and for patients with ADRD. And so in this study, we used a nationally representative 20% sample of Medicare bennies from 2018 to 2022. We used both fee-for-service claims data files and the minimum data set. We use the MDS to identify SNF stays and the Medicare chronic conditions data warehouse to flag patients with ADRD. And we define an encounter as being delivered via telemedicine if it was billed using one of Medicare's list of CPT codes that are eligible for reimbursement via telemedicine, or if a service was billed with a telemedicine specific modifier code or place of service. And we characterize nursing homes as being high or low telehealth facilities using the percent of encounters that the facility delivered via telehealth. And for our second aim, we use a diff approach to estimate the association between being a patient of a high versus low telehealth SNF from the pre to post period. And we characterize the pre-period as the years 2018 to 2019, and the post period as the years 2021 to 2022, with 2020 being a washout period and excluded from the analysis. Okay, so I'll go into our key findings. So we found that roughly 1.5% of all SNF services were delivered via telehealth in SNFs from 2021 to 2022. And I'm not showing this here, but there was a decline in telehealth use from 2021 to 2022. The three most common types of visits in SNFs delivered via telehealth by far were facility discharge management services, telephone evaluation and management services, and psychiatric diagnostic evaluation services. Among all patients, those who used any telehealth in SNFs were more likely to be slightly younger, so 65 to 74 versus 85 or older. They were more likely to be less clinically complex, and that they had a lower hierarchical condition category score, and they were more likely to be dually eligible. And then from our second aim, and using our diff and diff model, we found that receiving care at a high telehealth nursing home was associated with, sorry, just checking the chat, was associated with a 0.59 increase in telehealth services per patient quarter in the post period, and an increase in nursing home evaluation and management services. We also saw a small increase in mental health visits and an increase in other specialty visits. And the findings in the ADRD subgroup were comparable. So then just to wrap up, we found that telehealth use accounted for less than 2% of overall SNF utilization in 2021 and 2022. And telehealth uptake in SNFs was associated with an increase in overall healthcare services, about a 12 to 16% increase from baseline utilization in the pre-period years. And our next steps here are really to focus on changes in healthcare use among visits where telehealth uptake was higher, in order to disentangle the extent to which telehealth is replacing versus growing overall use of care in those areas. And we're also looking at some quality of care outcomes. And then finally, we'll be doing some semi-structured interviews to understand why certain SNFs are more or less likely to adopt telehealth, how they're deploying these tools, and their strategies for telehealth provision moving forward. Okay, so I will stop there. I know I'm at time.
Thank you so much, Gianni. It's a lot of pressure to be the first one to start us off, and great job and really interesting work. Next up, we're going to have Clara go ahead and share her slides. Clara Scher is an advanced PhD candidate at Rutgers School of Social Work, and upon graduation, she'll be beginning a postdoctoral training program at Weill Cornell Medicine again. So let's go ahead and have you start.
Hello, everyone. Thank you for having me today. My name is Clara Scher, and I am an advanced PhD candidate at the Rutgers School of Social Work. And today I am presenting from a pilot study of my dissertation titled The Feasibility and Acceptability of Conducting Walking Interviews with Black Older Adults Aging in Community with Dementia or Mild Cognitive Impairment. So walking interviews are a qualitative interviewing method that is conducted by researchers who are accompanying individual informants on outings in their familiar environments, such as their neighborhood or a larger local area. Participants are often responsible for determining the location, route, duration, and speed of the walk. And walking interviews have been used widely to explore neighborhood context for aging, and particularly with those aging in community with dementia. And researchers have noted that walking interviews allow for getting more place-specific, richer data compared to sedentary interviews, as well as allow for shifts in traditional power dynamics that are inherent in research by really empowering the participant to assume a leading role in the research process. So while there has been a large body of research using this methodology with people with dementia, very few studies have focused on establishing the feasibility and acceptability of the walking interview methodology among older adults with dementia who are racialized as Black in the United States. And this is a key gap in the literature, given that Black older adults in the US are at increased risk of dementia compared to non-Hispanic white individuals due to the detrimental impacts of structural racism on health. So this pilot study sought to really address this important gap in the literature. So this study took place in New York City from April to August 2024. And to meet criteria for the study, participants were 60 or older, identified as Black or African American, self-reported experiences of memory loss or a diagnosis of dementia, could walk for at least 20 minutes, either with or without a mobility aid, and also had the capacity to consent according to the UBAC questionnaire. Participants were also encouraged to invite a care partner along with them to participate. So to identify recruitment sites, I used the Image NYC interactive map of aging tool, which you can see here on the left, to identify neighborhoods in New York City with the largest populations of Black older adults as shown in blue. Then I overlaid the locations of social adult day centers as shown with the small blue icons. I chose social adult day centers given that these sites often provide care for community dwelling older adults with dementia or mild cognitive impairment. So to recruit participants, I used culturally informed recruitment strategies and a known sponsor approach, which involved forming relationships with staff at social adult day centers who provided a warm handoff to recruit participants. And I also held what I called brain health workshops at the centers, where I provided education about dementia, strategies to improve brain health, and also provided information about the study. So, in terms of study procedures, there were three primary components. The first was a traditional sit down interview where I asked participants demographic questions and about their environment. Then, a walking interview where participants guided me on a tour of their local neighborhood. And then finally, I asked participants questions about their experiences of being part in the study. I engaged in reflexive memoing by responding to prompts from a framework on reflexivity that was developed by Richard Milner. And for analysis, multiple data sources were triangulated that included these reflexive memos, the audit trail, post-interview questions, and a recruitment tracking document. I used techniques from reflexive thematic analysis to analyze data, and then once the preliminary analysis was complete, I went back to the social adult day centers to hold workshops that I called participatory analysis sessions, where center members reflected on de-identified quotes from participants and provided feedback on the results. So on the right here, you can see the basic demographics of the study sample, which included 10 primary participants. Only one caregiver was consented and participated formally in the study procedures. In terms of key findings, there were two overarching themes with respect to feasibility and acceptability, including differences in positionality between researcher and participant and developing rapport with participants. So first, it was important for me as the researcher to be sensitive to physical and cognitive challenges that participants experienced. And this had implications for feasibility, such as highlighting the importance of really conducting capacity consent before participating and being flexible about the location and duration of the walking interview. Researcher participant differences in racial and ethnic identity played a role in the interview dynamic as well. And as an example of this, I probed on experiences of racial discrimination using language such as racism and discrimination, which elicited at times a strong negative reaction from participants. Instead of leading with language around racism, I learned to listen for when participants shared about these experiences more organically, and then use reflective listening strategies to really reflect back about their experiences in the way they themselves described. In terms of developing rapport with participants, it was important to build trust with social adult day center staff and older adults. And one way I was able to do this was through those informational brain health workshops. Participants shared with me that this was a really good way to introduce myself and my motivation for conducting the study, as well as to introduce the topic of brain health, which can be highly stigmatized. And then finally, it was essential to ensure the comfort and safety of participants at all times during the study. An example of this was being flexible about the location of study procedures to be responsive to participant needs. And I conducted study procedures in participants' homes, on a bench in a local park, at their center, or wherever they felt most comfortable. So in terms of conclusions and next steps, one major takeaway was the importance of forming partnerships with social adult day center staff and community residents with lived experience of dementia. And in this next phase of my research, I want to continue to build upon the relationships that I've already made, while also forming new partnerships, particularly with Black or African American scholars. Next, it was important to engage in culturally sensitive recruitment and dissemination strategies. And in future community engaged projects, I'd like to continue to explore the use of this brain health workshop and participatory analysis session to build authentic research relationships with community-based organizations and community members. In the future, I'd also like to include recruitment and interview materials in multiple languages, and as well advocate for changes to consent forms to minimize technical jargon that can be hard to understand. And then finally, I hope to conduct larger scale studies based on this pilot data that would engage a much larger cohort of geographically diverse social adult day centers and employ an ethno-racially and linguistically diverse research team. Here's the list of references and my contact information. Thank you so much.
Thank you, Clara. Such important lessons learned. Now let's go ahead and move to Annette Rodriguez. Annette is a program manager for the Center for Successful Aging at Cal State Long Beach. So please go ahead and upload your slides. Perfect. If you want to put it in presenter mode, yep, perfect.
All right. Hi, good morning. My name is Annette Rodriguez, and I am a gerontologist. I received my master's degree in gerontology from California State University at Long Beach, and I am currently a program manager at the Center for Successful Aging at CSULB. And as part of my thesis project, I researched and developed a handbook entitled Montessori-Based Approach for Alzheimer's and Dementia, Handbook for Implementing Activities in an Adult Daycare Program. So, okay. Adult daycare programs serve as an important resource that offers an effective intervention to an increasing population of persons living with dementia. Loss of cognitive function is a challenge to both persons living with dementia and their caregivers, and ADC offers a solution to this challenge by providing care for the person living with dementia and respite care for their caregivers. However, existing studies indicate a lack of quality and standardization of ADC programs, and the existing literature focusing on Montessori for dementia care lacks specific guidelines for ADC programs. So to increase utilization, meaningful and person-centered ADC programs are needed in dementia care. And a Montessori approach has been found to offer deliberate, evidence-based care that provides the most innovative solution to deliver meaningful person-centered activities. Despite this, a notable absence remains in literature dedicated to providing education on the benefits of the Montessori approach, particularly in relation to the development of programs in ADC settings. So as a result, the project aim was to address the gap and apply evidence-based research by creating a handbook to implement a Montessori approach to dementia care within an ADC program. My methods were to conduct a thorough literature review, to review existing websites and existing books on Montessori-based activities. I completed the process to become a certified Montessori dementia care professional, observed 4 memory care communities, 3 of which were Montessori inspired, and interviewed 4 program directors of memory care communities, 3 of which again were Montessori inspired, and compiled an inclusive list of steps using the framework for reporting adaptations and modifications explained, as you see below, to develop Montessori-based activities for an ADC setting. And then the next step is to write a handbook that outlines how to develop and implement a Montessori for dementia care program in an ADC setting. And then I asked the handbook review panel, which consisted of 5 experts in the field of aging, to review and provide feedback on the proposed handbook draft. And the last step was to incorporate that feedback and make any necessary revisions to finalize the handbook for publication. Some key findings were that a Montessori approach to dementia care improves engagement, happiness, and quality of life for the person living with dementia. It reduces anxiety and aggression and withdrawal, slowing the progression of symptoms, thus resulting in an overall sense of calm. And also reduced medication use from 11 to 4 medications, lowering infection rates and decreasing falls among long-term care residents. And some of the feedback from the handbook review panel were that it was nicely organized and well-written, thorough and well-researched, fantastic number of resources and research without being overwhelming, beneficial statistical information, an easy guide to follow, great information regarding ADC programs, that the activities were arranged in appealing cookbook fashion, as you see here on the screen, and activity sections were beautifully displayed and explained, and additional quotes were significant and inspiring. The handbook advances existing research by extending Montessori for dementia care benefits to a setting most aligned with the needs of today's demographic shift, promoting interventions that aid in improving the quality of life for older adults and solving a current challenge existing in the field of aging. The The project was awarded Outstanding Graduate Project by the CSULB College of Health and Human Services in 23 and 24. It's been published through Barnes and Noble and presented as a poster presentation at the Gerontological Society of America Scientific Meeting in Seattle of 2024. And it is also utilized as a training tool to support interns at the Center for Successful Aging who are participating in the Alzheimer's Orange County Respite Program, a collaborative project with CSA. Some of my next steps are to disseminate further the completed project to ADC program directors, local senior centers, and professional organizations such as California Association for Adult Day Services and agencies that focus on the care of those persons living with dementia. As well, a next step would be to design a comprehensive training program aimed at equipping individuals with the knowledge and skills necessary to effectively implement a Montessori-based approach to adult daycare. And I would disseminate the training program in person or via Zoom. These are my references. Thank you very much.
Thank you, Annette. Really fascinating kind of a program there. Well, we'll go ahead and move to Min Hee, who I know does not have slides. So Min Hee Kim is an assistant professor at Rutgers, the State University of New Jersey in the School of Nursing. So if we can just bring down Annette's slide here, we'll go ahead and highlight Min Hee. So perfect. Thank you. Go ahead.
Yeah, I'll go without slides. So hello, everyone. My name is Min Hee Kim, and I'm an assistant professor at Rutgers University. Today, I want to share a research finding from my K99, a Career Development Award supported through the National Institute on Aging. So in the past few years, researchers have started quantifying the prevalence of potentially missed or delayed dementia diagnosis, and which is much higher for racial ethnic minority old adults. And my work extends this line of research and ask whether and how delayed dementia diagnosis contribute to inequities in health and healthcare outcomes, including the survivorship. So to do so, we use a sample of older adults from the Health and Retirement Study who have had cognitive impairment incident from the survey, as it regularly assesses cognitive status over time. And we infer the timing of former clinical diagnosis from the Medicare claims record. So in a monthly longitudinal data format, we constructed two time-varying measures, whether they received former dementia diagnosis through Medicare, and the amount of diagnostic delays. And these two measures were included in the pooled logistic regression analysis. And we estimated whether Medicare diagnosis and the delayed amount were associated with the rate of death, death or mortality, while adjusting for well-known covariates, including the age at the time of clinical diagnosis. And what we found is that the amount of delay increases the rate of death, but also having a Medicare diagnosis itself increases the rate of death too. The finding that the Medicare diagnosis itself was associated with the higher death rate is likely because we cannot fully capture the ways in which other conditions brought old adults into the medical systems and their diagnosis documented, sort of a selection into sicker people into the healthcare system. So I'm working on applying more robust method to account differences in social and clinical conditions at the time of diagnosis and the variations, heterogeneity within this simple approach, such as by diagnosis type. And of course, working in this area is quite challenging. But also very exciting because it questions whether Medicare system is structured in a way to support old adults at high risk of dementia. And it has been a year since I'm wearing a hat as a board member at the nonprofit serving home and community services to racially and ethnically diverse population in West Washington area. So it became more evident that the state and local policies are fundamental in shaping lives of individuals and families and direct care workforce. So I'm directing my research program toward more actionable research, asking how policies around primary care and Medicaid home and community-based services shape different pathways of dementia care. And my R00 phase research also asks questions, ways in which structural racism explains the racial disparities in timely dementia diagnosis. And we are using an additional study cohort, the REGARD study, or the reasons for geographic and racial disparities in stroke. So please feel free to reach out to me if you have any insight to share and collaborate. Thank you so much.
Thank you so much, Minhee. It's great to hear all these different ways people are working with communities and addressing their issues directly. So let's go ahead and bring up Catherine Kennedy. Catherine is a gerontologist and a health science specialist at the VA Providence Healthcare System. So let's go ahead and have you pull up your slides.
Wonderful. So thank you for having me. I'm delighted to present my in-progress study as well. Here we go. So this title of my study is really training of nursing assistants in Veterans Affairs Community Living Centers. And this is a study funded by the VISN-1 Career Development Award program here locally in New England. And I am at the Providence VA healthcare system. My study is really a pilot that was motivated by first the non-certification policy for nursing assistants in the VA CLCs, or community living centers. These are VA-owned and operated nursing homes across the country, and this non-certification policy was a concern of the operations leaders. So they wanted to get insights on the training experiences of nursing assistants and investigate the quality of those experiences. And then secondly, we know about the prevalence of dementia in veterans in these environments, and also their high rates of mental health conditions compared to community nursing homes. Over the last 10 years in the VA CLCs, rates of distress behavior in dementia have risen, and this is really not a symptom of dementia, but a way that people communicate unmet needs. So, and training is one modifiable factor that can address staff knowledge and competence with responding and preventing to distress behavior. So in this talk, I will present some preliminary findings from my ongoing study, and the aims of my study are to identify the patterns in training and certification for nursing assistants, and to explore how they relate to their choices and commitment to work in the CLCs. The second aim really focuses on nursing assistants as well, and how their training and certification relates with their job outcomes. So what I did was I used a multi-site case study approach where I recruited 4 community living centers with varying rates of turnover and tension among nursing assistants from 2022. And the recruitment process was intensive, that involved union approval, recruitment of the site level leadership, and also nursing executives at each site. Then I was able to meet with the CLC leaders, including the nurse managers and often the medical director. Then I scheduled a 2-day site visit and largely recruited nursing assistants and other staff while I was there in person. I also printed flyers in advance, but that really did not work as well. So over the summer, I ended up completing 30 interviews with staff to elucidate their training experiences. And all but 2 of the interviews occurred in person. 17 of the interviewees were nursing assistants. All were certified except 2, and those were grandfathered into the system and had long careers as nursing assistants. And 13 of the interviewees were nurse leaders. Transcripts were audio recorded using Microsoft Teams while I was in person conducting the interviews, and then those transcripts were basically audio, they were transcribed verbatim into text. The analytic approach was and is ongoing. We are using qualitative content analysis, and we combined a theory and data-driven approach to construct the coding frame that was inspired by PHI's 5 pillars of direct care job quality. Preliminary findings is that the training nursing assistants receive is important in their consideration of employment, job commitment, and their satisfaction. But there are other factors, and many factors that they also consider, such as pay, workload, teamwork, and relationships with veterans that they serve. A second finding was that nursing assistant tailored and standardized dementia training is needed, both at initial hire and then ongoing. Nurse managers and nursing assistants expressed desire for more training in mental health and psychiatric conditions, and also with dementia, in knowing how better ways to respond to veteran distress behavior. Finally, it's clear that training modifications are needed to address barriers such as high work demands, and also staffing, and also cater to the learning preferences of the nursing assistants. Their preferences are largely to have more frequent and hands-on training, and a dislike for the current status of training and reliance on a learning management system called TMS. Staff, namely the managers here, talked about the difficulty of taking nursing assistants off the floor to provide training, and had some really good suggestions about how to improve the delivery of training. So in conclusion, my next steps are to basically continue in my pilot study, and I am currently, I am writing a grant now to innovate the delivery of dementia education that uses a micro-learning approach to improve veteran distress with dementia, based on this pilot study and other ongoing work. Micro-learning provides a custom-made, engaging, and scalable strategy to meet learner and organizational needs. And I'm excited about, I recently learned about a platform called QStream that's being used already at some of the sites for survey preparedness. And this platform could potentially be leveraged to provide dementia and other kinds of education to nursing assistants. Also, the literature shows that secondary outcomes from this type of education could include changes in job satisfaction and burnout. So thanks for your time, and I welcome you to contact me with your ideas.
Thank you so much, Catherine. Fantastic. So let's go ahead and move to Nasim Firdows, who will, let's see, have Catherine first pull down her slides here so that Nasim can get her slides up. And so Nasim Firdows is an assistant professor at Northeastern University. So please go ahead, and I see your slides popping up and seeing perfectly there. Thank you.
Yep. Hi, everyone. So everyone can hear me well?
Yes.
Okay. Hi, everyone. Thank you for the opportunity. I am also presenting the research in progress that I have. I have very preliminary results. We got these results just 2 days ago, and I totally changed my presentation to present my most recent study. And in this study, we decided to study determinants of provider type in emergency department settings in urban and rural areas. And So it's because the ED visits have been increasing substantially in the US, and we see that more responses. The responses are heavily on providers like NPs and PAs. We wanted to see whether like the response rate is different in rural urban areas, considering the acuity or emergency of the condition of patients. So for this study, we use National Hospital Ambulatory Medical Care Survey, which is a national survey of ED visits in the US. And we use data from 2017 to 2021. And the population that we had were patients who were categorized. Oops, I forgot to go to the next slide. The patients were categorized by acuity and location. By location, we categorize them based on by metropolitan and non-metropolitan, which metropolitan is defined as based on county populations higher than, more than, I guess, let me just check to make sure I'm saying it right. The county population more than 20,000, and for less than 250,000, and for less than that, we put it as non-metro communities. And for the provider type, we categorized it into ED attending physicians, NPPAs with ED attending physicians, and NPPA without any physicians' involvement. And then we looked at the interaction effect between MSA and acuity level, because as I mentioned, the goal was to see whether there is a difference in rural urban areas in the response by provider type by the acuity level. And we just simply did logistic regression to model provider type across variables. We controlled for patient characteristics as well. Just to give you a glance or descriptive stats of data, we had 83,282 ED visits, and overall 74% of visits were responded by ED physicians only, and 14.4% involved NPPA with ED physician, and 11% involved NPPA without ED physician involvement. And as you can see here, we can see the response by different provider types in metro and non-metro areas, and we can see by triage level. And specifically for like no triage or immediate, we can see that the response in both rural urban areas is more ED attending physicians are responding compared to NPPA. And but for semi-urgent, non-urgent, in urban areas, 20% of response is without any physician involvement. But in non-metro areas, 12% or almost 13% is without any physician's involvement. And then this is just preliminary results of the interaction between immediacy and MSA level. For like the provider type, the reference group is ED attending physicians only, and then we have the NPPA with ED involvement and NPPA without without physician involvement. And we have this by triage level, MSA, and the interaction between MSA and triage level. And as you can see here, there is a significant difference in provider type by MSA and acuity level. And immediate emergent cases in non-MSA are more likely to involve NPPAs without attending physician. And we can see there are regional differences here as well. So I'm not going to talk about all these results, but we have very interesting results. And we also looked at like insurance type. I forgot to put the results of insurance type here. That's also very interesting. So in rural areas or in non-MSA, which we call it rural, they rely more heavily on NPPAs without attending physician, particularly for high acuity cases. And as I mentioned, insurance type results were also interesting. I forgot to put them here. They play a critical role in determining provider type as well. So the next steps of this research are, I'm just going to briefly talk about this. Like first, we want to investigate health outcomes, but the more interesting thing that we want to do is that we want to also study how state level policies on NPs and PAs can affect like the response of the provider's response. Because as you might already know, we have state level policies on NPs and PAs that in some states they are restricted from providing care. Specifically, like if I say for NPs, in some states, NPs can only provide care if there is a physician that can supervise them. And as we know that there is shortage of physicians, I'm very interested to see what happens in those rural remote areas that they have shortage of physicians and NP's policies restricts them from providing care without a physician supervision, and the same thing for PAs as well. And then the next step also exploring policy implications to improve equitable ED access in rural settings, which we know they are in much need. And I'm happy for any ideas and any comments that everyone.
Thank you so much, Naseem. Lots of information packed in there, and always exciting to get some hot off the presses results shared with the group. All right, let's go ahead and have Alfred Boache pull up his slides. And everyone's done so well here that Alfred, fortunately, you won't have to be pressed for time. So if you want to go ahead and bring that up, Alfred is a graduate research assistant at the University of Maryland, Baltimore and Baltimore County. So please go ahead. I know it takes just a moment here. I just want to make sure you unmute also, Alfred.
Can you hear me?
Yes.
Okay, I'll go ahead and share my slide. I'm sorry,
All right, I know we tested this earlier, so I know it will come up.
it's still.
And as he pulls them up, I do want to encourage our audience members to feel free to reach out to our speakers if you have questions and use the chat function, or reach out to them if there's an email, or use the Q&A function if you have any questions.
Can you see my screen now?
Yes, yes, we can.
Okay. Hmm.
I know you're trying to get to full screen here. Oh, I see it's working.
Okay.
I see it thinking.
Yeah, it's saying not responding, so I'm kind of.
We'll
Okay.
just give it, oh, there we go. It just takes a moment.
Yeah. Hmm. Is it better now? Can you see my screen?
We can see your slides. It's just not in presenter mode, but if this is just as well, I think this would work just fine also if it's having trouble getting to full screen, but we can see your slides. Oh, and right now we can see the presenter mode. So you would have to go up to display settings and just switch it out.
Hmm.
Perfect. Yeah.
Okay. I'm so sorry.
Oh, it's okay. It looks good now.
Okay. So my name is Alfred Boache. I'm a second year PhD student at University of Maryland, Baltimore and Baltimore County. And thank you to my co-authors. Today I'm presenting on addressing nursing home challenges, empowering direct care workers through team functioning strategies. And as we all know, the United States is aging, and we have a lot of older adults who will need long-term care services and support. But then these care and support will need to be of high quality to address the complex care needs of older adults and persons living with dementia in residential care settings. But then we also need to strengthen the long-term services and support workforce to meet this critical need. But there is a long-standing recruitment and retention challenges, such as high workloads, low recognition among certified or direct care workers within these long-term care settings. And COVID-19 also taught us a lot of lessons where we had a lot of CNAs leaving the direct care workforce due to high rates of infection and a lot of other issues going on within these settings. But then team functioning has been identified as instrumental in care work, as leaders in these long-term care settings are looking for innovative ways to keep the workforce to continuously meet the needs of these older adults or residents in these nursing home settings, because team functioning has been seen to improve direct care workforce engagement and empowerment, strengthens interpersonal relationships, increases productivity, and increases person-centered care outcomes for residents and improves job satisfaction. So this research, the aim of this study was to understand the perspective of direct care workers and identify strategies that nursing homes can use to improve team functioning and communication in service of improved resident outcomes. And so we did a phenomenological qualitative research where we used semi-structured interviews that lasted about 30 to 45 minutes. We interviewed 25 nursing assistants from 2 high-quality nursing centers, and we compensated them with $25 for their time. And this study was IRB approved from Georgia State University, and the PI was Dr. Morgan. And the participants, we had 23 Blacks, 23 CNAs who identified as Black, 23 were women, and their modal age was between 41 and 50 years. Some had some college degree and high school degree. And their average income was around $30,000, between $30,000 and $40,000. And we use a thematic analysis. Now, these are some of the findings. So we found out that in asking them how to build and maintain these high functioning teams, one of the approaches was to formalize these teams, to formalize team structures. And so they needed to make it formal within the nursing home setting, where we have, like, maybe from the top, we had a good administrator, we had a good DON, and other co-nurses agreeing and coming together to make things work, because teamwork was important. And they all saw that it was something that could help them to maintain and continuously provide person-centered care to nursing home residents. Another way was to dismantle clerks, because they felt that most often than not, there were formed clerks within the nursing home setting. And so you needed to be part of a certain group, even to get promoted or to be seen as qualified for a position. And another way was to use collaborative strategies. And so communication was very key in their conversations. And so they realized that it was important to communicate with each other if they wanted to thrive as a team. Or when you build teams, it is important that you encourage communication, because if you do that, then people are on the same level or on the same page. And then it's not like just one person moving and then doing everything, but then you communicate with each other and then you work together. And then the final way to build these high functioning teams is to tailor check-in options. And so to have daily meetings, phone calls, emails, live like family, develop like an email conversation or email structure, so that you can share information across, so that you carry yourselves along instead of some leading and then some being left behind. And so from this, we learned that teamwork is really helpful, because it reduces workload, burnout, and the need to work short, because we saw that during COVID, most of these CNAs had to work short. And then also it helps to provide fairness and equity and reduce turnover that is reported within these nursing homes because they prioritize team building and empowerment through shared decision making, where they set clear goals coupled with support from their organization. And high-performing teams, we also learned, drives organizational goals and success and makes them more competitive. And so there's a need to prioritize these team functioning strategies. And so the next steps for this work is that we also learned through the research that, and then also learning from the importance of trauma-informed approaches and incorporating them within these nursing home settings. We realized that there was a connection. And so going forward, we are looking forward to extending this research and to incorporate these high-functioning strategies in these trauma-informed approaches of safety, choice, collaboration, trustworthiness, and empowerment, because we plan, or our plan is to offer values that could be infused into the positive work cultures and support high-functioning teams within nursing homes where everybody is working and they are working collaboratively, yet achieving goals and providing person-centered care to nursing home residents within long-term care settings. So thank you for your time and attention.
Thank you so much, Alfred, and thank you to all of our speakers. What a wonderful set of research that everyone has done. I mean, 7 fantastic presentations. I wish we had time for more discussion for all. And I do hope that you all who have attended today, that you share out the work of our wonderful network members. And if you have an interest in doing such a thing and present your own work, please reach out to me, and we will certainly find ways to highlight more work. Or if there's areas that you want to hear more about of the research that was presented today, also let us know, and especially via the website, there's a place for you to let us know what topics you want to hear more about. I know we only have a couple minutes here, so we don't have really much time for much discussion, but I just want to check if anyone had any pressing questions for anyone while we still have people here on the line. And it can even be among the panelists themselves if you have any questions for each other. But no pressure if not. So maybe without seeing any immediate hands or Q&A coming up, this has been recorded. We will post it online in the next few days. And so this will be something that will be available for others to see, and we'll certainly share it out on social media too, and want to encourage others to do so that everyone can see the fantastic work you're all doing. Thank you so much to everybody for putting in such great work to stay on time and really share such rich work today. So have a wonderful day, and hope that 2025 is off to a great start to you all. So have a wonderful day. Thank you, everybody.
Thank you so
Thank
much.
you.
Thank you. Thank you. Nice to meet all of you.
Thanks.